some of this stuff. All right, we did the welcome stuff. We did all that stuff. Everybody know who everybody is?
Sure.
We talked about our syllabus and professional student handbook, responsibilities and expectations. I think we talked about that. We know who you are and what you want to do. Okay, just to reiterate this point, you're responsible for everything that we kind of covered. In fact, at the end of this lecture, we're going to ask you to sign all those signature pages that you have a packet of in front of you. Okay? I think it may have witness next to it. So the person next to you can be your witness. They can sign it and print it. And as long as those documents are filled out and all of them are turned in, that's what we're expecting. Okay? So again, we just kind of briefly summarized some of the things that we thought were important. But again, it's a living document, and you know you're expected to live by it, and you can go back and reference it as you need to. All right, and the information about me, blah blah blah. We talked about Miss Quintanilla. We're going to talk about her. Trust me, I'm just going to talk about that woman. Diane, are you listening to me? We're being recorded. You can go back and listen to this. Okay, and again, we kind of talked about some of the other instructors. They are task specific. Some of them have expertise. Phil Ward here will come in and do some really good stuff for us. And again, we have people just kind of specialize in different areas. I guess Miss Quintanilla was inundated by grades, so don't be asking her about your grades. And then she doesn't want anybody to ask her about classroom stuff. Just like I really don't mind you asking me questions about clinical stuff. I just can't give you the best answer. Same thing with her. She just probably doesn't mind, but she just can't give you the best answer because that's not what she does. She does clinical stuff, and I do classroom stuff. Okay. We talked about Mr. Jarvis, and again, you can always ask questions that we might not answer or answer clearly. He'll be happy to do that for you. We talked about the text, and again, my opinion about that is you need to get it. If you get a used one, I'd use a used one. Again, I've said that that is a good reference piece of information. And now that we've added the chapters to it, it allows you to go back and read that stuff specific to that chapter. Okay, and it says references not required is some kind of pathophysiology reference. I'm going to go into some pathophys, but that's not really what we're about in the EMT level. Even though I love going into pathophys, you know, we can get lost in that if we're not careful. You get in pathophys when you get into the paramedic level. And one thing I want to say is, you know, is I'm pretty user friendly, but once you get into the paramedic program, it's kind of a, you need to survive on your own. I mean, they bring the information, they bring it hard, and they bring it clear. But you need to keep up, and there's a lot of information they teach in there. Drug references, that's really kind of up to you if you want to get a drug reference. And then workbook. There's a workbook that goes with the textbook. If you haven't already bought it, I don't know that I would encourage you to get it because you're probably not going to have time to get into it, okay, unless you're just a professional student and this is the only class you're taking. Okay. Again, there's some of the options for the D2L. There's a podcasting link, course policies, quizzes, we talked about that, presentations, and additional learning aids. And if there's any kind of assignment, and I haven't done it yet, but if there's any kind of special extra assignment that I throw at you, it'll probably go via D2L. And I'll say go to D2L to get that assignment, okay? Okay, so again, that's kind of what you're responsible for in D2L, responsibility of the student to attain mastery of these objectives and basis of presentations and exams. Okay, generally on the due dates for the quizzes, I'll just tell you when I want them due. It's probably not going to be listed in D2L because D2L is something new for me too, and I don't want you guys holding your breath waiting for D2L when I could just say, hey, by the way, the next 3 quizzes are due on Wednesday. Okay. Okay, there is disability services. Again, they can only give accommodations after approved by student services. You need to let us be aware of any special needs that you might have, and we'll make the appropriate accommodations. Now understand that when accommodations are made here at the college, National Registry not necessarily, they don't have to follow those accommodations. So just be aware of that. Okay, we have TC Student Services, which help with, again, study skills, not specific to this class, but just in general. The better way to study. How should I study? Is group study better? Individual study? We kind of encourage a little bit of both. What I would encourage when you get into group study is, you know, if it turns out after your first session of group study that y'all spent the first 30 minutes actually studying and the next 2 hours grab-assing, then that's probably not the right group for you, okay? Unless you like that. I mean, that's up to you. But, again, you're not going to learn a lot, okay? Test-taking skills, they talk to you about that kind of stuff. I think a lot of people are very bright, but sometimes there's a disconnect from the time that I've absorbed the information, I've learned it. Now when I get to the test environment, oh man, I freak out. I have test anxiety, whatever you want to call it. You have issues with that. And again, that document I gave you, the last 2 pages, that actually has some pretty good ideas. On caffeine, for example, you shouldn't be drinking it before class. A lot of people think, well, that makes me alert and aware and all that kind of stuff. It may cloud your thinking. So again, writing skills, reading skills, there's not a lot of math, so you can kind of let your guard down about that. When you get to the Paramedic Program, that stuff will pick up. Okay, again, we talked about the class attendance. Please don't push the issue with the 16 hours, and then there won't be an issue to address. And these are the classes we're telling you right up front that are considered mandatory. In other words, you may have all the Saturday sessions. You go, man, I can't make all these Saturday sessions. I'm going to miss one. Well, just make darn sure it's not any of these right here, and they're listed in the syllabus. So don't miss the extrication day or the what we call the mass casualty incident drill. Again, this is more of Ms. Quintanilla stuff, but really your clinical is a really good environment for you to take advantage of learning. And we'll teach you this stuff. You'll get that stuff in here. We'll show you how to do the skills. But when you get in the field, people go, oh, man, that's where I really got my learning on. I felt like I really was able to apply what I learned in the classroom in the field setting or in a clinical setting. So those actually kind of become very cohesive, and it really kind of brings things together for you, especially if you're kind of cloudy on some stuff, okay? Okay, it says you must inform the clinical coordinator of that you will not be at a clinical before the shift begins. And again, no-shows affect your clinical grade. So you start out with an A in your clinical grade. You don't start out with I'm working up to an A. You actually start out with an A. And for every deficiency that you have, that brings your GPA down in your clinical grade. So you can fail your clinical grade. Okay? Okay, and then the FISDAP, you need to do that. There's going to be some scheduling deadlines in your handouts. Did they put the deadlines in your handouts? I didn't even look at it closely enough to see if there was deadlines in here.
I think it said that all clinicals have to be scheduled by June 21st.
Okay, there you go. Where's that under? Where did you read that? In the syllabus?
I think in the student information packet.
Oh, okay. Okay, good. Okay, I don't know that this affects any of you, but if you are employees, current employees, you can't count I'm working today with this ambulance service, and I did 8 hours, and I'm getting paid for it. By the way, I'm going to use those same 8 hours as a clinical. It don't work that way. That's all this is trying to say. And it also includes volunteer activity. So if you made a call and you're a volunteer with Rogers Fire Department and it was a good, legitimate call, you were a volunteer. You weren't recognized as a student. You can't count that time. We talked about the exams and the value of each one and stuff like that. And we talked about kind of how that works, so I don't know that there should be any questions about that. Okay, and so, again, in order to pass the class, you have to have a minimum of 79.5. So that's what it takes to get through the class. And we certainly talked about how your grade is made up of. Okay. All right, your effective evaluation, and that's just your daily activity with us, okay? Again, it says in class you should act as if you were at work. Again, things like being respectful, knowledgeable, compassionate. You must pass evaluation to pass the course, and a copy of evaluation is in the D2L. Okay, this is important for those of us that don't successfully complete the class for whatever reason. You drop, you decide you don't want to come back anymore. It is your responsibility to officially drop the program. Okay? What we'll give you is an incomplete. That's far better than getting an F. Because if you don't officially drop the class, I have no option. I'm required to give you an F. So it's much better to withdraw, you know, with the office there. Okay? And we talked about the hours that you're required to do. What we did talk about is this. It says that when you run with an MICU, you have to have at least 60 hours and at least 3 ALS runs. An ALS run is what we call advanced life support run. So any procedure that was done that's above and beyond your level of certification is considered advanced life support. An example would be, you know, as an EMT, you're allowed to give aspirin and nitro. You're not allowed to start an IV. So if you go on a chest pain call and an IV was never started, and all that really happened were a certain couple of things up to your level, that's not considered an ALS call. But if a paramedic shows up and an IV started and a 12 lead is given and morphine is given, guess what? It becomes an ALS call. So that is a legitimate ALS call. What that last bullet says is you can actually get 60 hours and only get 1 ALS call. What does that mean? You have to schedule additional rotations so you can get those last 2 ALS calls. Okay, and again, I told you that your clinical grade is really it's up to you. You start out with 100, and you can keep that if you don't have late paperwork, you don't not show up for a clinical and things like that. And so you start getting a reduction of 5% for each additional clinical absence, and no-shows count for 2 additional clinical absences, so, you know, it starts to add up. Alrighty, and we kind of talked about this already. We went through briefly the class, the section A and the section B and things like that. All right, and some expectations of you guys, and we kind of mentioned some of these already. We told you guys to work hard, demonstrate your eagerness to learn in every environment you're in. You should be professional in everything you do. Don't get me wrong, we're going to have some fun. We're going to cut up. We're going to make some jokes, stuff like that. But again, we really expect you to act in a professional manner, okay? Be respectful, considerate, and nice to everyone you encounter. And then a good question to ask yourself is, what more can I do to learn and demonstrate my commitment? Okay, so the Department of State Health Services completes an FBI criminal history, fingerprint requirement, and you can actually turn in an application and be denied for some kind of deficiency, and they have a whole list of deficiencies, okay? If you happen to be denied and they say you're not, you can take the test, but we can't issue you certification until you're out of your probationary period, and that has happened. Actually, when people have been on probation, they took the test, they withheld their certification until they said, okay, you know, that's counted as community service, you showed good faith, blah, blah, blah. We're going to give you a certification. What I'm talking about is two different organizations, because up to this point all we've said is what? National Registry is who certifies you, right? Well, the state wants their money too. So after you successfully pass the National Registry computer-generated exam and pay the fee, then you got your certification. But you're not allowed to practice in the state of Texas without what? A certification from who? Texas Department of State Health Services. So what you do with them is you get the application, you fill it out, you submit your fee of $70, $80, and guess what? The good thing about them is what? There's not another test you have to take with them. You've already taken your National Registry test. You've already passed that. DSHS, all they want is what?
Money.
There you go. So you submit your money, and they send you a state certification. Okay? Okay, and again it says DSHS application takes time, should begin the process now. And there's a Paramedic Systems webpage, and I'm sure there's some kind of information, a handout that we gave you that gave you more information on that. Okay, we talked about the paramedic programs. Again, you can't get into a paramedic program until you successfully completed this one. All right, questions and or concerns from anyone? All right, the next section is going to be Introduction into Emergency Medical Services. And this is kind of a long one here. Okay, does everybody have this lecture? Very good. And I think I have a clicker here. I really don't want to be tied to this silly thing. Piece of crap. They're probably recording all that crap I said, aren't they? What did I do? There we go. Anyway, some of the origins, where did we come from? If you think about professions, you know, EMS is a fairly new profession. You know, we've only really been in effect in late 70s, and in some areas of the country, early 80s is when we actually started. So back in the day, this is not a too uncommon occurrence. You'd have maybe a hearse that would pull up to a bad car wreck, and you know, if business were slow at the funeral home, they might drive real slow. No, I'm kidding. Ambulance services actually started responding to traumatic events. In fact, when I mentioned that I was teaching in Rio de Janeiro, Brazil, and one of the things they were telling me is their EMS systems are a little different in different parts of the country. And where I was teaching, they said, unless you have a contract with an ambulance service, they won't pick you up if if you're in a home. Okay? Now, if you have a contract, they'll pick you up anywhere, but otherwise, you have to be on the street for them to respond to you and take care of you. Okay? So the joke was, if you have a heart attack, have somebody kick you out the house. But anyway, it started from trauma. That's where ambulances started responding to. They really weren't responding to heart attacks. They were responding to bad car wrecks and stuff like that. And they said, you know, how can we get a better outcome, patient outcome? And so they said, you know, if we start training people and start providing them with some core knowledge, maybe we can make them better at what they do. So there are some, obviously we like to attach ourselves to federal legislation. Okay, the Highway Safety Act of 1966 was one of them. Okay, the Department of Health and Human Services Medical Act of 1973 was yet another, which had about 13 components to it. Okay, and again, this is just intro information. A lot of this is really not that important. It won't be seen on your exam. Okay, the Texas Health and Safety Code, Title IX Safety, talks about emergency medical services. And so when we go back, if we go to court and they go, okay, what type of training did you get? Did you follow the DSHS guidelines? Okay, well, we go back and say, yes, we got approved through your agency, we followed the curriculum for the National Registry, and we gave the test, or we sent it to the National Registry to get a test, and so we followed all of the processes as you wanted us to. Okay, DOT again stands for Department of Transportation. Again, we mentioned that it started in the early 70s, and the current revision is about to be changed. It's 1994. It hasn't been changed yet. In fact, even though they've changed the EMT curriculum, the CPR curriculum, we're still going to teach you the last curriculum, not the current one. And the reason we're doing that is because the National Registry hasn't changed their exam questions on their exam. So if we teach you the current stuff, you're going to be picking those answers, which are not going to be what the National Registry is looking for because they haven't changed their exam. In fact, the exam won't change until December. Now, if you happen to take your exam after December, which I don't see that any of you would, you know, you'd have to follow the new CPR guidelines. Okay? So some of the purposes of all this is, again, is they wanted to see, because what we were seeing is, depending on which part of the country you were from, some states had some really aggressive protocols, okay, and some had some very lax protocols. So there wasn't any universal training. I'll give you a good example. When I went to Guanajuato, Mexico, and I was teaching classes, and the day one of the class, I noticed there was 4 guys in the front row, and they all had paramedic patches on. It said paramedic on there. And so I just kind of casually said, okay, which program did you go through here, and how long was your program? The first guy said, you know, I went for 6 weeks of training to become a paramedic. This guy says, I went for 2 weeks of training to become a paramedic. This guy says, I went for a whole year to become a paramedic. Now, which one of them was right? I'm thinking the person that's gone through a year is probably closest to fitting the curriculum that we were following here in the States. So part of what we were trying to do down there is have them follow the guidelines that we set here for in the States. If that makes sense. So that even us in the States, we weren't universal in our approach to what we were expecting from the different programs throughout the nation. Okay. So again, standardization of training programs. They're starting a class tonight in Detroit, Michigan. There's an EMT class starting there tonight. What do you think they're talking about tonight? Same stuff with just a different accent, right? All right. Standardization of levels of certification. So if you're an ECA here, you're an ECA wherever. If you're an EMT basic here, you're an EMT basic in the state of Arizona. Okay? Now, what do you think the differences might be? Do you think we're going to talk about scorpion stings here in the state of Texas as much as we would in the state of Arizona? Probably not. Do you think we're going to be talking about jellyfish stings here in the central Texas as much as they would on the coast of Florida. There's a big difference. So what I'm telling you is the deviations you're going to be seeing in some of the programs are going to be basically driven by geography, where you live. Okay, in Alaska we see a lot of cold weather emergencies. Are you going to see a lot of cold weather emergencies in Arizona? Not nearly as much. So, you know, geography kind of drives how we deviate from the teaching curriculum to a certain extent. Okay? The other thing we're looking at is the standardization of patient care. We want to make sure that all patients are treated equally based on the level of the provider providing the care. Okay? In other words, we don't want EMTs starting IVs here and not starting IVs somewhere else. Now, as an EMT, can you start an IV? Yes or no?
Technically you can, but you're not authorized to.
You're not authorized to unless, and that's a good answer, unless you're authorized to. And I'll give you a good example. We would have our EMTs that would complete our program. They get hired as a tech in the emergency department at Scott & White. So what Scott & White would do is train them to start IVs and train them to put in Foley catheters and train them to do 12 lead EKGs. Even though those are EMT basic skills, who authorized that? That agency, and they had some kind of medical direction. So they felt like as an EMT basic they had the core knowledge, but they wanted to improve that level of certification. So it was more as an employee, as a tech in the department, they were allowed to do that. Not because you were an EMT basic, but because you were a tech, and by definition as a tech you have to be at least an EMT basic. Does that make sense, kind of, sort of? Okay. Okay, EMS systems, they kind of differ by city, county, state. We just kind of talked about the three, we kind of mentioned three different agencies here, didn't we? Temple Fire has what?
Yes.
They have the fire department that provides, well, we're actually considered first responder with ALS capability. Meaning that we get there, but we do have ALS capability. Who else shows up with us? Scott and White. And we jointly take care of patients and we're transported. Williamson County is a different agency. They work separately. They're EMS people. They don't have any of the fire training. They don't want to do that. Their job is delivering, you know, paramedic level care. Harker Heights Fire Department. They're a fire-based EMS system. The employees that are on the ambulances are actually firefighters, but they're also paramedics. Okay? So they're different. We have air transport. Nobody mentioned that they wanted to become a air paramedic or a flight nurse. Anybody have a desire to do any of that stuff? I'll have my wife come in and talk to you guys. She's actually a flight nurse, and she works for a group called PHI, which is Petroleum Helicopters Incorporated, and they actually took over Scott & White's medevac system, and they're a quality bunch. And what I'll say about air transport and air service providers is generally you don't get out of school and say, hey, I want to become a flight nurse or fire paramedic or a flight paramedic. You actually have to have a lot of experience before they even look at your application. Now, it depends on which agency you're talking about. Some agencies don't have the same standards as other agencies. As an example, my wife's service, you have to have like 3 years of critical care experience in a coronary care unit to work for them, okay, as a flight nurse. So, again, they're all different. All right, there's non-transporting agencies, people like first responders. I kind of gave you an example, right? The fire department is a non-transporting agency. Unless you did what one of our medics did and they got tired of waiting on the ambulance, so they loaded the patient in the fire truck and hauled them to the hospital in the fire truck. Is that right or wrong? What do y'all think? I'm asking.
I think it's right.
It sounds right, doesn't it?
Yeah.
It sounds pretty cool, but it's not the right thing to do, trust me. Because we actually, we can get a lot of trouble for transporting patients because we don't have a license to transport. How did you secure them in that fire truck? Oh, we laid them in the back. Did you use seat belts? No. We don't have no seat belts on the floorboard. Okay, so that's your first gig. Okay, so you see where I'm going with that? Even though it sounds reasonable, and the reality is, and oftentimes in mass casualty events, a lot of people are transported in the back of pickup trucks, right? And there's nothing really wrong with that. Okay, the mass shooting we had in Fort Hood. They were transporting patients by whatever means. I thought it was kind of interesting that clean fire department showed up at Fort Hood to mutual aid and help them. And the medics showed up with their ambulance. They got out. They were talking to people. They went back to their ambulance. Their ambulance was gone. What the heck happened to my ambulance? Well, some kind of commander said, hey, there's an ambulance. There's wounded soldiers. Go. I don't give a crap what clean fire says. We're going to commandeer their ambulance, and they did. Okay, that's the way the military does stuff. Okay. And then again, we talked about non-transporting, like first responders, and they all kind of contain similar kinds of components. I mean, we all are there for the same reason, right? And it's just that we're not really required, and we're not really allowed and certified to transport patients in the back of fire trucks. Okay, we talked about medical direction, and we talked about medical director a while ago, did we not?
Yes.
And again, I think we're kind of clear on medical direction. It's just a group, okay? If I'm transporting my patient to Scott and White as an example, and I'm not really sure what I should do as far as patient care, I call them up and I ask to speak. I ask for physician traffic, and I say, hey, doc, this is what I've got. And medical direction is really, really handy when you have a patient that's being stubborn and really needs to go to the hospital, and they keep telling you, I'm not going to go to the hospital. And by the way, can a patient tell you that? I'm not going to go to the hospital? Can a patient that's just cut their arm off deny transport to the hospital? Yes, they can. So patients have a lot of rights, okay? So that's when you put medical direction on the phone. And oftentimes what you'll find is I have attempted to convince the patient to go to the hospital. They say no. The minute they start talking to the doc, what do you think happens?
Okay.
The doc convinces them to go. And that's good. I'm not going to get my ego bruised because I couldn't convince them. The right thing is what? They get to the hospital. And I could care less how they get there. I really don't care. I mean, I've been doing this crap way too long where I just say, I don't care how you get there as long as we get you there. All right. There is the forms of medical direction could be online and offline. Online, obviously, is what we just talked about. Hey, doc, this is what I got going on. What do you want me to do? Okay? And a good example might be you show up to a private home. There's a little old lady, she's 80 years old, her husband is lying there, he's dead, he's not breathing, she's visibly upset, and as soon as you walk in, you're just doing what you're supposed to do. You acknowledge, you do your assessment, find out they're not breathing, they don't have a pulse, so you get on her chest and start bouncing on her chest and start cracking ribs, and the little old lady starts screaming, going, don't do that, they're a DNR. And DNR stands for what? Do not resuscitate. And legally, guess what? I won't resuscitate him if she can do what? Provide a document that says do not resuscitate. Here's where it gets kind of sticky. Okay, she's upset. She's got that document in a safe place, which is a safe. She goes to safe and she can't remember the combination. Is that a reasonable kind of scenario so far? Yeah. She's not going to remember the combination if her husband's dead. Okay? So what do? She's upset because we're cracking ribs in his chest. And he said, don't let them do this to me. And here you are breaking ribs in her chest. So what are you going to do? Call who? For what? Why are you calling them?
For approval to continue?
or not. Exactly. Say, hey, doc, this is what I got going on. This little lady, she's upset. Her husband's been down for a while. They can't produce the DNR, but she said she's got one. I believe her, but she can't get to it because she doesn't know the combination. What do you want me to do? And she's probably going to say what? Go ahead and discontinue your efforts. You see where I'm going with this? When you have a difficult decision to make and it's not within your capability to make a decision you're comfortable with, let them make that decision. Does that make sense?
Let me ask you this: if the patient does not resuscitate, is your partner on the phone with them, and you have to still do the resuscitation at the same time?
If they can't produce a DNR, yes. And so we kind of gauge what we do based on family reaction. We kind of gauge it on the circumstances. There's a lot of factors that we use here, okay? And so I really kind of read the environment, okay? And here's another kicker with it. The husband could have signed a DNR document. The wife was okay with it. But today when you walk in the house, she has the DNR in her hands. And she reluctantly hands it to you and she says, he's a DNR. And then all of a sudden she says, but please do something for him. Now she's got a legal document that says do not resuscitate, that's signed by him, that's signed by his doctor, and it's got his name on it, and it says do not resuscitate. He's lying here dead, that's what his wishes were. But now she's been married to him for 60 years, she goes, please do something. Keep in mind you got a legal document in your hand, and she says please do something. So my question is, what are you going to do?
Honor his wishes.
He's dead. Who's still alive? Is he going to whine about you doing CPR on him? He's dead. Is she going to whine about you not doing CPR on him? Absolutely. Okay? So again, even though it sounds like that wasn't my wish, my wife changed her mind at the last minute, do CPR. Okay? Always err on doing more than less. Less in this case is what? Doing nothing. More in this case is what? Doing something. Okay? So that's what I would do. And that's what most of your medical directors will actually tell you to do now. Okay? Alright, so we know what online is. How about offline? Is offline medical direction good? It's really good. Because without offline medical direction, guess what? Think about it. We couldn't do caca without getting on scene and calling the doc saying, hey, this is what I got. I'm walking in the room. This guy's pale. He's sweating. He said he's got a chest pain. It's 10 out of 10. He said he had a heart attack 2 years ago. What do you want me to do? What's the doctor going to say? Why don't you grow up and act like an EMT? Does that make sense? So what is he going to do? What is she going to do? They're going to write a Bible, a document, a set of protocols. And what do these protocols say?
What you cannot do.
Exactly. These protocols might have a cardiac section, they might have a diabetic section, they might have a seizure section, childbirth, snake bite. You see where I'm going with that? And so each one of them says, okay, this is what you're allowed to do. And you go all the way to step 5. When you get to step 6, it says call med control for further instructions. Does that make sense? Mm-hmm. So protocols are there that allows you to do what? Start treating patients, to not tie you up. Now this is a little different from nursing care. If you think about a nurse in a clinical setting, they really can't do what? Unless you're talking about an acute ICU setting, a lot of the other nurses, if you're a patient in the room and you're having pain, the nurse says, let me go see if the doctor will let me give you some pain meds. Have you heard that before? Mm-hmm. Absolutely. In an ICU setting, guess what? I'm having pain. Okay, I'll crank up the pain meds. And us in the field, what do? As long as the protocols allow us to do that to a certain point, we're allowed to do that stuff, okay? And again, you always have to have some kind of quality improvement avenue so that you can evaluate what you're doing. Are we doing good? Are we doing bad? Where can we improve and things like that? Okay, the communications part of that. You know, there's different ways that we communicate with one another, with the hospital, with our bases and stuff like that. We can do it by radio technology, which is what we use probably 9 out of 10 times. There is some cellular capabilities. A lot of people go, well, cellular is good because if my radio goes down, then my cell phone will still work. The tornadoes that happen in Alabama, we have family there. My wife does. And the cell phone's one of the first things that took a big hit. Okay? So you can't count on that in a crisis situation, but it's just another resource that's available to you. Now, I will say this, we are starting to use cellular in different parts. An example is this. Let's say I have a patient who's got chest pain. So I run a 12-lead EKG on them. Okay? And the 12-lead, as opposed to 3-lead, gives me different views of their heart and specific to what part of the heart is actually infarcting. Okay? So I take a picture of that 12-lead with my iPhone and I send it to my medical director, and guess what they have? They have a picture of the 12-lead. So we're encouraged to use that kind of technology now. So if Apple knew we were doing that, they would use us in one of their commercials. You know how the fire department, they go, fire departments use Duracell batteries and blah, blah, blah. Well, Apple's going to say, hey, guess what? EMS folks are using our iPhones for this. Okay? There's data, and data is, you know, most systems are now, they have some type of computer, maybe a mobile data terminal or something like that mounted in their fire truck or ambulance or police car or whatever. And it's just a way to send more information. You got hard information, you can look at a screen and go, okay, you know, when I get in my engine, I have a computer that sits right in front of me and it tells me caller name, tells me the history of the complaint, where I'm going, it has a map if I want to follow the map and all that kind of stuff. It gives me special notes. It gives me ongoing information. Because most of the time when I'm dispatched to a call, the dispatcher is still on the phone talking to them. Or actually the call taker is. Because in the communications sector, if we were to call 911 right now, there's two people working that particular call. One is the call taker gathering the information, and as soon as they get the information they need, they are to the level they need, they automatically send that to who? The dispatcher, and the dispatcher will actually send the appropriate resources to that call. Okay? Okay, and most systems have now gone to 911. Okay, dispatch center, obviously, some of the components that make it a good system is that the design of it, it's workable, it flows. Okay, the other component, obviously, is equipment is current. It's not got a lot of breakdowns. There's backup systems. We've often said that, you know, if the comm center goes down and the computers go down, you know, a lot of dispatchers don't know how to dispatch old school. They really don't, and so they're lost with a lot of without that technology. Again, staffing and training, you have to have the right people. My understanding is the dispatch community, they have a pretty big turnover. They keep going. It's a high stress job. It really is. So they have a hard time keeping people in those positions. You want to get them trained up. You want to make sure they understand policies and procedures. We've actually, this is kind of interesting, we've actually put a lot more responsibility on the dispatch community. And I'll give you a good example. When I first started years ago, if you picked up the phone in the city of Temple and said, I got to go to the bathroom and I hit my toe on the coffee table and I think I broke my toe. Okay, we'll send you a fire truck. I'm at the station, they encode my station, and they go, Engine 3, you need to respond to this address, broken toe. And what do you think we did? What do you think we were required to do? We were required to get in that engine and drive as fast as we could to get to that broken toe. Does that make sense? It doesn't make sense. It wasn't until a couple of years ago that we kind of got smart to go, that's a huge liability that we're sending here. We should not be sending people, our firefighters, in a fire engine running code 3 back then to a broken toe. So nowadays what happens is we have something called priority dispatching. So what happens is when you call in nowadays, present day, I broke my toe, okay. So they're reading these cards. Unless there is no life-threatening issue associated with that big toe that you just broke, now they'll get on the radio and encode your station and go, engine 3, you need to respond to such address, priority 3 traffic on a broken toe. Now priority 3 means no lights and no sirens. Now does that make sense? So it took us a while, but we finally wised up and said we don't need to be responding to this broken toe, in this fashion. Okay. So again, we're giving a lot more freedom to the dispatch community. And so the dispatch center is a link between the public and the system components. Okay. They're a really vital link in what we do. Okay, ambulance service. There are, not all ambulance services are created equal. Okay, some systems are really high tech. Some people are just catching up. Some people struggle with the EMS community and things like that. Their equipment and maintenance, obviously, is really going to be dependent on the budget they allot for that kind of stuff. And again, education is really important. When you guys get out of school, you have this initial education. And again, one of the things we mentioned is in a very short period of time, that information will do what? It will no longer be very accurate. Okay? So what you should do is you should be getting something called continuing education hours. And what their design is to allow you to stay current on what are we doing now for heart attacks? Are we doing for heart attacks 2 years from now what we did, in 2011? And the answer is probably not. Okay, first responder agencies or related agencies. First responders, again, first responders could be a volunteer fire department that shows up first and they start initiating care. Now they don't have to be certified as ECAs or EMTs. They just need to be volunteer firefighter people. Okay? Law enforcement folks usually have maybe basic first aid. In other words, when you pulled over by a trooper and he stopped at a car wreck, he could have been a former paramedic in his former life, so he's going to have that knowledge, but he's not working under a medical director. So guess what? He can't treat you like a paramedic even though he still holds his paramedic certification. Does that make sense? Mm-hmm. So it's based on, it's kind of like me driving from here to Dallas, and I stop at a bad car wreck. And so I stop and I start rendering care. And now shows up the ambulance. And the ambulance shows up, and there's an EMT and a paramedic, EMT and a basic and a paramedic on there. And the paramedic, I get in the back of the ambulance with them, and they say, "Can you start this IV for me?" And the correct answer is what?
Nope.
No.
I'm a paramedic. I'm allowed to start IVs.
You're not authorized in that area.
That's a pretty good point. But the reality is, and yes, that's probably the best answer, but that's really not an invasive kind of thing. Do you think? Now, if I was doing a surgical crike on him, here's a different scenario. Let's say I showed up, and this person had a crushed trachea, and that was a new paramedic, and I've done surgical crikes, and I say, "This guy needs a surgical crike," and he goes, "Well, I've never done one, and I don't know how to do it." And I go, "I do." Now do you see where it gets kind of murky here? Yeah, starting IV is not that big a deal. Doing a surgical crike is a little bit different. It's more invasive. So that's kind of where you get in the gray area. So the bottom line would be what?
To help out.
To help out, continue to help out. But would it be okay if I'm not really sure what I should or shouldn't do to have him call his medical director? Does that not sound like a reasonable kind of thing? Yeah. Absolutely. And vice versa. What might happen is you work in a car wreck on the interstate and all of a sudden a car pulls up, and in the car somebody comes running out, and he says, I can do that surgical crike for you. And I'm going, well, who the hell are you? Well, I'm a trauma surgeon over at Parkland. Okay, what is your response going to be? How do you know he's a trauma surgeon at Parkland Hospital and he just didn't stay at the Holiday Inn last night? How do you know? What are you going to do? I'm asking because I want to know.
Wouldn't they have some type of certification?
Sure, you could ask for, you could credential him to make sure she is a trauma surgeon, right? What's the other option?
Call the hospital.
There you go.
Don't keep thinking you
What's the fun always comes where? Call the hospital and let them handle that situation. And so usually this is the way I handle this. When that hot shot surgeon shows up, and she shows up, I'm going to go, she goes, this is what you need to do. And I look at him and go, who are you? Well, I'm, Dr. Such and Such from Parkland Hospital. I'm I'm a trauma specialist. Okay. All right, you're going to assume total care of this patient. I'll do exactly what you tell me to do. And they go, well, what does that mean? That means you're going to get in the back of the ambulance with me and you're going to go to the hospital with me. That's the only way we're going to do this. And usually they do what?
You got it.
It's all right. I'll help you. Hey, what you're doing is okay. But you have a lot of options here. And probably the best option is to do what? Well, you've already mentioned it. Call med control. So what you could get is physician to physician online talking to one another. And even though this deviates from what my protocol says, if this doc is saying this is what I want you to do, as long as everybody's happy with that decision, I'm happy with that decision. Okay? All right, we kind of got off key here. Remember law enforcement, you have the police and sheriff's department. You got these guys. And then you have federal agencies. A lot of our law enforcement community are carrying AEDs. You guys know what AEDs are?
Mm-hmm.
They carry something called an automated external defibrillator, which is a shock box, and you see those in public places now. Well, these guys are putting them in the back of their cars. And when I first started in the fire service, and I can say this because I've worked with Temple PD for a long time, they would not touch patients. That's not my job. I get $50 a month, but I'm not touching them to be to do first aid. Nowadays, these guys, I love them to death. They're a lot of my good friends. These guys will run over you to get to the call before you. Because they got that little box in the back of their trunk, and they're going to shock somebody. But I guess what I'm getting at is the level of compassion, the level of care, the level of service that police, they've actually have taken a big interest in providing care now. Okay. All right. Other organizations, we're going to work with regional organizations. Your community may respond to a hazmat incident as an example, and a regional hazmat team might respond, so you might be working with them. And again, if it's a hazmat incident, okay, and a good example would be, we look down the road and there's people laying down outside the semi-tractor trailer and there's a brown cloud over them, and you're thinking, I'm an EMT and I'm a paramedic and I'm going to go take care of them, and this hazmat captain says to you, you're not going in. Who's right and who's wrong here?
Yes.
Who's in charge?
Yes.
If this is a hazmat incident, it's like if you go to a shooting, a mass shooting, and there's still an active shooter, and the cops say you're not going in, guess what?
You're not going in.
Okay, so what dictates who's in charge?
Depending on the
It
situation.
depends on the situation. And again, we're just kind of scraping the surface, but when you get into command structures and stuff like that, you have things like a singular command, or you have something called unified command. Singular command is one person, and it doesn't matter which agency they're working for or represent, they're calling all the shots. In the unified command system, what we have is when we get to that hazmat incident, and this was, they're also hauling drugs, so we got a legal issue, the police want to be in charge, we've got a hazmat incident, hazmat team wants to be in charge, we've got people on the ground, EMS wants to be in charge, and we got a little bit of fire. So fire department wants to be in charge. One of these people has to be in ultimate charge of this, and based on what the need is, they set the priorities of what gets taken care of first. Okay. That's just... Okay, you think that public information education is really, really important?
To an extent.
To us, you think it's important to us? Let me help you. When I first started, if you died in the field, you probably died. If you went to cardiac arrest, you probably died. There wasn't a whole lot of bringing you back. If you died from a cardiac arrest event, and it took me 5-6 minutes to get there, the chances of me bringing you back are not very good. Nowadays, how many people are taught to perform CPR? Okay? Where do you have AEDs? All over the place. So what do you think the success ratio of our CPR saves are? Do you think they're still 0%? Or do you think that we're improving on the percentage of... And why do you think it's better? Because we're educating what? The public. Absolutely. And so we have, things like, bike safety programs and things like that, swim programs, gun safety, all that kind of stuff. Things are going to help the public be more informed, things like that. The fire department offers a seatbelt installation program for new moms, new parents. So before you're allowed to take your kiddo home, if you're having Scott and White, you're required to go through and get your car seat professionally installed by a seatbelt technician. And guess what? Those of you that have put car seats in your car, you know that our guys have to go to school for 2 weeks just to learn how to put a car seat in a car? Yes. Absolutely. And you're going, oh, I just run the thing through there and I click it and click it and click it and I'm good to go. Well, it works, but I've seen a lot of car seats ejected from cars and rollovers because somebody didn't click it incorrectly. They didn't follow they didn't tighten it, they didn't put the safety fastener and all that kind of stuff in it. But anyway. All right, healthcare system. There are categorized hospital emergency capabilities. In other words, if you live in a huge community, you may have a burn center, you may have a cardiac center, you may have a head trauma center. So based on where you live, you may have those different capabilities. And then again, in a smaller community like ours, you have a one system catch-all here, okay? In other words, you're going to have Scott and White, that's our level 1 trauma facility. VA is not going to take care of acute care patients, okay? And probably King's Daughters is not going to be able to do that either, okay? Well, they're King's Daughters or Scott and White now?
Yeah.
Scott and White Children's Hospital, right? Okay. You're going to have to develop rapport with other healthcare professionals. Again, you have to engage and talk to them. Again, I don't know what funding reports and records are there. Okay. The continuum of care, in other words, what are the phases in managing a patient? There's the first phase, which is us, the out-of-hospital care. And that's really the first exposure the patient might have to any level of providership, okay? The second phase is we transfer them to the emergency department. And then the emergency department's job is to do what? Stabilize them and send them to what? And maybe specialty care facility, i.e. we have a patient that's got 60% third-degree burns. We can't manage them. We have to send them to where? A burn center, absolutely. So that's where the definitive care comes in. All right, do you think it's important to have disaster plans? My God, ask Joplin, Missouri. Ask Phil Campbell, Alabama. Hackleburg, Alabama, where my wife's from. I mean, those communities were completely wiped out by tornadoes. Okay? So, major incident response is really, really important. This is the Murrah building bombing that happened in Oklahoma City. Okay? These should be designed by EMS and designed to integrate with other agencies. If you just develop a disaster plan and all you do is include your own agency, and none of the outside agencies are going to come in to help you, you're screwing up. You need to start practicing playing. Make sure you have radio operability, interoperability. In other words, my radios can talk to your radios. Okay, we know where staging's at. We know where our emergency operations center's at. I mean, all these things you need to kind of pre-plan. Okay, in the city of Temple, we have one emergency operations center. That's over at the city landfill. We built Station 8, which is going to have the other emergency operations center. Why does the city of Temple need 2 EOCs?
Could it be because we have the level 1 trauma possibility?
What happens if a tornado knocks out one of the EOCs? Okay, so again, you're just kind of developing and thinking ahead, going, okay, if this center's knocked out, maybe the other one won't be knocked out. Okay, so plus the new one that we're building is going to be much better than one at the city landfill. It rocks. Okay, quality improvement include things like protocol reviews and updates. Is it important for your medical director to give you a test on your protocols? Make sure you know them. Is it important for her to recognize that your protocols are no longer valid and we need to tweak them, we need to adjust them, we need to find out that current technology says this medication is no longer good for that condition. Maybe we need to up the dosage, decrease the dosage, or try a different drug altogether. Absolutely. Okay? Remedial continuing education. We test people. If they can't pass the protocol test, we remediate them. Okay? We give them continuing education, because once we teach you this stuff, are you going to retain that? 6 months from now, I'm probably not. I'm going to remember some of that stuff, and some of it's going to be very clear, and some of it's going to be kind of fuzzy. Okay? Risk management, loss control. In other words, find out, we found out that we're hurting people on ambulance 32. And the reason we're hurting and they're going out with back injuries is because that stretcher happens to have a problem with it, and it doesn't latch like it's supposed to, and people are jamming their backs when they pull that ambulance out of the ambulance, or that stretcher out of the ambulance. Outcome studies. If we're activating the cath lab, we'll find out that we could do that a little bit faster because we're doing a study on it. Then let's change that. What can we do to change that? And again, system status management. A lot of services are doing that. And what you'll find is, as an example, Scott and White, I mentioned, has so many ambulances in the city of Temple. They also have ambulances outside the city of Temple in the different smaller towns. Well, if all 10 of the ambulances, as an example, in Temple are on calls, guess what we're going to do with the ambulance outside of town? We're going to bring them in. Same thing. We do that in the fire service. If we have a bad fire, we have all our engine companies tied up, except for 2 or 3 of them, and they're all going to be on the south side, then I'm going to move some of my engine companies toward the center of town to relocate. Okay? So that if they have to respond to a call on the north side of town, they're a lot closer. Right? Okay, roles and responsibilities, safety, and levels of training. We talked about these different levels of training: ECA, EMT Basic, Intermediate, and Paramedic. Okay, the priorities are always going to be yourself, your partner, bystanders, and eventually the patient. Had I asked you that question before you saw the slide and I said, who's the most important individual when you show up to call, most of you would have been tempted to say what? The patient. Absolutely. Okay? Now, do you think this is a good scenario? Is there a lot of badness in that scenario?
Not a lot.
I have a guy that I don't know why he's on the ground. He's got a club. He looks pissed off. Now we're in a tight alleyway. There's a lot of badness there, okay? Do I need to be in an alley with him? No. What do I need to be? He's breathing. He's moving. He's not acutely ill, okay? So what I'm probably going to do is wait at the end of that alleyway until Popo gets there and say, you go get him, bring him out here, and we'll take care of him. Is that okay? Am I being CS when I do that? No. I'm just being practical. There's no reason for me to go in there with somebody that's a potential threat. Okay? Really isn't. Okay? Now, why does he have that stick? Is it because he's pissed off? Or is it because his blood sugar is low? Could it be both? Yeah, it could be either one of them. Okay?
Or is his leg hurt and he's trying to use it as a crutch?
I'm not sure. Okay, some safe behaviors for you as far as the health. It says, and it's kind of funny, it says no destructive activities, but typically people that get into this profession are classic type A personalities. And classic type A personalities are adrenaline junkies. And so what kind of activities do they do? Destructive behavior. I will see if I can do this without getting hurt. I hope I get hurt just a little bit. A little hurt's not bad. Okay? You should also rest, get in physical, and you know what I think is just as important as physical conditioning? Mental conditioning. This job really takes a toll on you. It really can. It says do not push your body past the limitations. You should have a pretty good awareness of what your, those parameters are. What are my limitations? I sit there and watch commercial and I start tearing up. Is there anything wrong with you? No. I'm not a sissy if I cry. I just have feelings. Okay? But along those lines, if I show up and there's a little kid and kid's not breathing, I probably want to cry and I'm probably gonna cry, and that's okay. But I'm probably not going to try and do it while I'm taking care of that kid. And there's a fine line there. Trust me, because the first time you make that call, you're going to be that person that may not have any response to it all, or you may be that person that's going to break down because I got a kid this age at home. It's going to happen. Now, I'm going to say this to you guys. If it happens to you, please don't get so distraught that you say, I can't do this anymore. This is not what I'm cut out to do. Before you make that decision, seek some help, seek some counseling, because I'll tell you, a long time ago, I showed up to a call and I had a breakdown, and one of the guys looked at me and said, are you crying? And I go, yeah. He said, you should probably get out of this business.
Oh, wow.
And he almost destroyed my career that day. Had I followed his directions, I probably would have given it up. But, I guess what I'm trying to say is I would rather have somebody working next to me that is capable and willing of showing emotion than somebody who has no emotion at all. Okay? Okay. You should wear personal protective equipment. And again, that's stuff like gloves and masks and gowns and whatever that scenario calls, reflective vests, whatever that situation calls for. Survey the scene, look for hazards, listen to others, listen to what other people are telling you. It's really important to get that first responder first report. They might tell you, when I first got here, this guy had fallen off a ladder and he was shaking violently like this for like 2 minutes. They don't know what this is, but you kind of think, well, that kind of sounds like he had a seizure. And that's what it sounds like to me. So make sure you listen to what they're telling you. Okay, and again, these are some of the things that you guys are going to be responsible for. They've actually added 2 skills to this class, which is really cool. And one of them is called a King airway, which is actually you're dropping a tube sound somebody's throat. And then you're going to be doing in-tidal CO2 monitoring, which is really cool too. And just since we've kind of moved this program over here, we've added a lot of stuff. CPAP, in-tidal CO2 monitoring. There's a lot of stuff that we're adding. Glucometer checks. So as the profession grows and matures, we're saying, oh, that's no longer an ALS skill. Let's make that a BLS skill. Because King Airways, we're an ALS skill. Now we're making the basic skills. Some of the other things you guys are going to be responsible for are how to use the AEDs and shock trousers and how to deliver a baby and all that cool stuff. We talked about the medications that you're going to be responsible for, and actually oxygen is considered a medication. Before I can get my oxygen bottles filled in the fire department, I have to have a prescription from a doctor for that, so it is considered a med. And the other things are extrication and rescue. No, we're not going to actually put you in bunker gear like we used to do and give you a tool and say, go cut somebody out of a car. We actually used to do that in the old days. We quit doing that. I mean, that's just something that we just don't see that you're going to do unless you actually become a firefighter, fire person kind of thing. You know? All right, roles and responsibilities. Again, you should, above all else, be a patient advocate. And that essentially means to do what? Do what's in the best interest of your patient. Okay? And that can be something as simple as, I'm driving through your town, I have a car wreck. Me and my kids are separated because there's 5 of us, and we're going to the hospital in different vehicles. And my husband was behind us in his vehicle, and he says, I don't know how to get to your hospital. Can you show me? Sure, just follow us. Or give them a map. Something. You see where I'm going with that? Help them out. Do something for them. Okay? Maintenance. Are you guys responsible for vehicle maintenance and equipment maintenance and stuff like that? Depending on what agency you're talking about, absolutely. Our guys are required, my crews, when they show up at the station every morning, they're required to check that truck out. They have to check everything that operates on that to make sure that it's working, and the inventory and all the quantities there and things like that. All right. And these are advanced level skills, intermediate skills, and again, paramedic skills. All right, professionalism. Okay, again, that's the definition of profession, the field of practice that requires specialized education and/or licensure. It's formally recognized by accreditation and certification, and involves a competency that is unique to the occupation. So that's kind of a picture of what a profession is. And again, it should be regulated internally and externally. Okay, we want to make sure that we're following the guidelines. Okay. All right. Do you think that appearance will open the door for you?
Yes.
Your personal appearance. I actually thought about coming in with, cut off shirt and a, rag over my head and cut off shorts and just kind of presenting myself. And I'm saying, okay, what do you think of me? You're going, I don't know. You probably would have said, hey, you're more of a hippie than I am.
That's exactly what I was thinking.
Yeah. But again, what do you think your leadership people should, how do you think they should look? And you guys become leaders when you work with an ambulance crew. People are looking for you for help. And maybe something as basic as just talk to me, give me direction, tell me what to do, stuff like that. So I think appearance, myself and one of the other captains, we have this discussion all the time. I talk about in the fire service, we're allowed to wear T-shirts and or the blue uniform shirts with the collar brass and all that kind of crap. And I say to him, my preference is to wear the uniform shirt with all the collar stuff and the press shirt. He goes, a T-shirt is fine. And if he and I walked in the room, who would you prefer to take care of you?
Professional. Probably.
Does it matter to you? I'm just asking, does it matter to you how we look? Because there's valid points for both sides. He said, as long as it's the attitude that's really more important. And he says we're laborers. We take care of people. We may be in a car wreck in bunker gear in a few minutes with this T-shirt on. And I say to him, but if you got a faded T-shirt on and I look like this, I think people are going to look at me and hold me in a higher regard right up front. You may be smarter than me, but at least they're going to look at me first because I project more, in my opinion, I project more of a professional image. What do you guys think about that?
Well, from my experience with the fire departments, being a volunteer, most of the time when someone like you shows up with brass and everything on, that kind of gives us okay, you're in charge, you're command. Where T-shirts are usually the guys like us that are doing all the manual labor, doing everything.
And I would agree that there's valid arguments for both sides. I don't totally disagree with him, but it's just he and I having this, we banter each other. You know what? You're a slob, Craig.
But I see his point too, that if
Right.
you're fixing to get into fire, you know, you have all that dress on, plus you're putting on your bunker gear on.
Yeah. I mean, there's valid arguments for both sides, but that's just my way of bashing him, saying you look like a slob. Okay. Again, attitude, because he said, you know, appearance and attitude, and I agree, they kind of go hand in hand. If I've got a better attitude than the person that's professionally dressed, yes, he's right and I'm wrong. Okay. Interaction with others, man, I think that's really important. I've learned that over the years. I used to walk in and I was a hotshot paramedic, and it just didn't matter what people thought of me or said about me. I just didn't care as long as I thought I was doing the right thing for the patient. And I learned that lesson the hard way. I walked into a hospital and they were taking care of a kid with a critical head injury. The hospital did not manage the patient very well. So I'm walking in and I'm taking care of the patient, doing IVs and doing all kinds of stuff for him. And the whole time the father's right on me. He's just kind of like, what are you doing? And blah, blah, blah. Just all over me. And I never bothered to talk to him because I was so engrossed in taking care of his son. In my mind, I'm saving your son's life. I don't have time to talk to you. So about a couple of days later, the chief calls me in his office and says, hey, we have a complaint against you. I said, for what? He said, this guy's complaining about you and how you took care of his son. I said, is he talking about how I managed his son? No. What's he complaining about? How you handled him. He said, you never bothered to talk to him. At the time, I was really pissed off because I thought, I didn't have time to talk to you because I was taking care of your son. But over time, I realized how important that was. If that were your son, and you all just wanted to be acknowledged, you would want me to talk to you. All I had to do was say, sir, your son's, pretty critical shape. I'm doing what I can for him. I'd like to talk to you right now, but I really need to take care of him. I need to focus on him. You think that would have probably set him at ease? Absolutely. So I learned that the hard way. Okay, your mannerisms and your speech is really important. Writing. And I'm going to pick on you kids in the class. You're like real young, and you're extra young, right? Y'all two are young back there? Y'all are young. And what do you think about your penmanship? You think it's good or bad?
I think mine's pretty good.
You think yours pretty good? Really? What I see nowadays, and it's just, I'm not picking on you, but what I see now is penmanship is a lost art. Okay, and most people now that write have horrible handwriting. And their spelling is just as bad because why? Take spell check. Okay? If I'm starting to type a word that's wrong, it gets red. Dumbass, that's not the way to spell it. Let me fix that for you. Okay? So I don't have to really think about that, okay? So I think a lot of what we were taught in the old days is really kind of gone by. Where I'm going with this is those poor penmanship skills are transferring over to your patient care reports. And so that's a legal document. That goes to a courtroom. And they can't decipher your printing skills. My kids have horrible handwriting. I tell them that all the time. And they go, well, I got it from you. I'm going, okay, whatever. But anyway, if your writing skills are poor, that's reflective of what? Because there is no spell check when you're writing it down. And so the likelihood of you misspelling a word is pretty high. Okay? So again, that reflects what? Believe it or not, they're going to judge you based on your penmanship and your ability to spell words correctly or incorrectly. That reflects poor patient care. Okay? And then we talked about knowledge and skills and participation and continuing education and quality improvement and stuff like that. Again, how do people perceive your actions? Are you perceived as a professional? I don't know. What do you think of yourself? Do you think you can improve in some of the things you do? I think as we go through, we're going to find that I'm a little short-tempered and I really hate to repeat myself. That's one of my weak points. I hate to repeat myself. And when somebody doesn't hear me and I'm asking a question, I kind of go, the next time I ask them a question, do you have... Oh, I'm kidding. All right. The personal attitude and conduct. I think these are all good quality traits. You should be confident in what you're doing. And people should look at you as confident and not cocky. I think they need to know that you're compassionate about what you do, that you have empathy. You don't want to feel sorry for them, but you understand what they're going through. You have good leadership skills. What do you look for when you show up and things are going bad? You want somebody in the room to do what? To take charge and have good leadership skills. That's what you're looking for. You want to have good sound judgment. In other words, the protocols say this, but you know what? I think this is probably the better thing is this. I'll give you a good example. There was a kid one time that was having a seizure in a school bus. Okay? And again, school buses are not ambulances. Stay with me, okay? So kid's having a seizure in a school bus, and he's a special needs kid. So it's right down the street from my station, half a block. So we get there, I'm assessing this kid, and I'm looking at the overall picture. I'm going, we just need to go to the hospital, and we're not going to take him out of this school bus and put him on a stretcher and cause him to have another seizure. We just ain't going to do that. So I looked at my captain at the time, and I looked at the bus driver and said, drive me to Scott and White. Here comes the ambulance right behind us, and I take off. The ambulance is like, what the hell are they doing? Well, we're going to the hospital. And so what do you think the ambulance crew, what do you think they were? Think they were pissed off because I transported their patient in a school bus? Mm-hmm. And do you think they told my medical director? Mm-hmm. Do you think my medical director talked to me? Mm-hmm. You think I got in trouble for it? Mm-mm. Why? The medical director, and I'll say this, the medical director at the time said, that probably, we probably broke a few rules here, but I see where you were going with this. So I'm going to defend this action this one time. But don't do it again. And my response was, if the same thing happened tomorrow, I'd be here in front of you. I'd do the same thing. Well, it turns out my wife ended up taking care of this kid a month later, and this lady started telling my wife the story about, yeah, my kid had the seizure in the school bus, and this fireman showed up, and he said he's going to put him in the school bus and take him like that. And my wife's just kind of listening like, uh-oh, where's she going with this? And she goes, you know what? My doctor, the kid's doctor, said that was the right thing to do. So I got lucky on that one. But again, I think a lot of it has to do with experience and sound judgment, making the right call. Even though it's you deviate from the standard of care, and I'm not promoting deviating from the standard of care, but what I am saying is if you deviate from the standard of care, be prepared to do what? Defend your position and document the hell of why you did it that way. Okay? Good moral character is important, stability and adaptability. Okay, again, that stability is bringing your personal baggage to work. Okay, if you're bringing your personal baggage to work, is that going to affect your performance and the way you deliver care to patients? Mm-hmm. It will. Okay, adaptability. If you're a hard-headed individual and you're not adaptable, you may have problems. If you get on scene and you come up with a game plan on how to pull this patient out of this car wreck, for example, and this is the only way in my mind to do this, and some new firefighter that just got out of extrication school 2 weeks ago say, hey, this is kind of what they're recommending, this is what we need to do. I've been doing this for 28 years. What am I going to tell this kid that's been in the fire service for 2 years? Let's try that. A good leader is going to listen. He's going to say, you know what? That sounds reasonable. Let's try that. Okay? So be adaptable. Okay? All right, and some other things that work hard, always demonstrate your eagerness to learn, perform well. You should be respectful, considerate, and nice to everyone you encounter. We talked about that. Be professional in everything you do. Gain respect through your appearance, knowledge, and behavior. Okay? And lifelong commitment to learning. You should always be prepared to learn and learn more. Okay, and we kind of talked about this, your EMT certification. We get you ready to take the National Registry exam. Again, you're going to have to to file your application with DSHS after you finish the National Registry. You can't get that certificate until after. You can apply for it, but you can't get it until after you get your National Registry. Okay? Okay, we talked about that. All right. Let's look at the schedule real quick before we leave, because I'm going to sign some quizzes. Okay. You guys meet again Wednesday night. I will not be here. Mr. Mincy will. The following Monday, May the 30th, we're off for Memorial Day. So our next class after that is June the 1st. So June the 1st, you guys should have completed the quizzes for the legal aspects, the human body, and medical terminology. So those first 3 quizzes need to be done by June 1. Show up with those completed. And where are you going to find those quizzes? D2L. Absolutely. So go find them, print them, complete them, and have them ready. Now, if you're not going to be here June the 1st, what are your options for getting those quizzes to me and getting them graded?
Email it to you.
Email them before the start of class or fax them. Okay? Now, again, if you have issues with some of the questions you're not sure, feel free to email me with your answers and say, this is what I think you mean. And I'll say yes, no, whatever. All right. Yes, sir.
When are we going to meet with Miss
Quintanilla?
Yeah,
I have no idea. Let me see if I can see it on here.
I didn't see her.
Probably, I would ask you to just contact her
But
and say, hey, when are we going to get to visit? I can't give you that date. Her and I have not visited about when she's going to come in. Okay? Anybody have any other questions?
these
What? Yes, those signature pages. Yes, thank you very much. I need all those back.